Professor Mosaad Soliman, he will talk about phenogenic erectile dysfunction. Where do we stand?
Isn't it interesting that a successful erection is mainly a vascular issue, while failure is something else? This is proved by the main mechanism of penile erection, which is arterial infusion and venous occlusion. So by definition, what do we mean by erectile dysfunction? It's the inability to initiate or achieve penile erection sufficient for satisfactory performance due to either a psychological, organic, or mixed causes with a surfing prevalence worldwide that's predicted to reach more than 300 millions by the next year and making a major health problem. So by age, we have those below the age of 40 due to mainly psychological causes in up to 10%, 40 to 70 years in 40% due to organic causes, and above 70 in 100% of the cases due to endocrinal causes. And by default, the organic causes means vasculogenic causes due to either endothelial dysfunction, arterial insufficiency, or venous leakage. So this is our main target today, is how to illustrate the vasculogenic causes and differentiate between the different types of vasculogenic impotence. Clinical assessment of such patients is counting totally on the patient word. You are asking a questionnaire for the patient involving what we call the International Index of Erectile Function, the IIEF 15, which comprises 15 questions. Each one is scored for 5, starting with confidence, quality, performance, maintenance, completion, followed by the frequency, satisfaction, enjoyment, and lastly, ejaculation, orgasm, frequency of desire, level of desire, coming to the overall satisfaction, partner satisfaction, and the level of confidence, and making a score of all these items. If the patient received a score more than 30, he means a normal situation, and less than 10 means a severe erectile dysfunction, but a more concise form is the IIEF, which involves only 5 questions, and if the patient gets more than 25, this means a normal value, and less than 7 means a severe erectile dysfunction. So how do we investigate such patients? It starts with intracavernous injection of 3 items, the babavrine, the alpha-adrenergic blockers, and the third would be some kind of vasodilator agents like the prostaglandin E1, followed by the duplex ultrasound, selective penile arteriography, MRA, CTA, dynamic infusion cavernosography, cavernosometry, and the shear wave elastography, and the peripheral arterial tonometry. And going through these items, we will follow the intravenous injection. And by the guidelines, it can't be used alone. It should be combined with some other things, like, because the penile rigidity is always subjective and cannot differentiate between the arterial and the venous leakage. Ultrasound is counting on the 2 main subjects: the peak systolic velocity, if it is less than 25, means arterial insufficiency, and if the end diastolic velocity is more than 6 and the resistance index is less than 0.6, it means venous leakage. Selective penile arteriography, it gives an idea about the traumatic arterial injury and the anatomical variation. The MRA is very helpful in delineation of the iliac pudendal and the proximal penile, while the CTA is equivalent to the selective penile angiography, but less invasive. And when combined with visual endoscopic images, it can be very helpful in diagnosis of difficult cases. Dynamic infusion cavernosography will detect the venous leakage, while the cavernometry will help detection of arterial insufficiency. And the shear wave elastography will help for detection of rigidity of the cavernous tissue. Peripheral arterial tonometry is helpful as it reflects the endothelial dysfunction. So we have a group of investigation which can differentiate between arterial and venous insufficiency, and emerging investigation that needs refining on the oncoming years. What if we have a venous leakage problem and we need to treat it? We can go through this by surgical ligation of all the superficial and deep veins with a success of around 25% only, or percutaneous embolization, either antegrade or retrograde, or revascularization by a surgical mean of the deep dorsal vein of the penis. And this starts with harvesting the inferior epigastric artery from the pubic area up to the level of the umbilicus, and making a track through the inguinal region to be anastomosed eventually to the deep dorsal vein, and this would be a success of around 68% of the cases. Or you go through a percutaneous, which is a duplex guided puncturing of the deep dorsal vein, castration, and then onyx embolization of the periprostatic plexus, the superficial and deep inguinal plexus, and ending up with total ablation of the venous leakage of the patient. This is evident by many ways. You can have seen a different anatomies, but eventually you don't leave the patient until all the kinds of venous drainage is totally ablated. This is helpful. And seeing all the periprostatic plexus, we can define it here, and it goes to the pudendal system. And after ablation, all of this system is totally ablated at this level. And you can start on a left side, and then you proceed later to the right side. And now we have total ablation of the left side, and then proceeding to the right side, and eventually everyone is happy. You can go through this area by doing this kind of ablation with the flow to the periprostatic, and then onyx embolosclerotherapy, and finally you end with total ablation of this part. And radiological success is followed here by a kind of clinical success, as evident by reversal of the end diastolic velocity at 10 minutes and 15 minutes. Again, everyone is happy. How we can achieve success? You can achieve success if you have more than 4 items improvement in the 6 IIEF at 12 months, or you can have improvement in the IIEF 15 score, and the mean difference is improved at 3 and 12 months. And lastly, you have improvement in questions 3 and 4 of the IIEF 15. Thank you.